We're very pleased today. We have with us Professor Peter Whitfield. Peter is the chair of the examinations committee, has been doing that for a number of years. Peter, thank you for making the time.
Thank you.
It's a hard task organizing the exams, isn't it?
Yeah, the exams, we run 3 written exams a year and an oral exam every year, so there's always that work base. And then of course there's improving the quality of the exams and the questions that we're asking all the time. Yeah.
So a lot of the potential candidates are asking what's the format. And for example, there's a part 1, there's a part 2. What's the part 1 format?
Part 1 format, this is for trainees who are partway through the training course cycle, but it's also for people who are not in the training course cycle. They can come and sit the exam, but it is a written MCQ exam. It's actually done on computers, and the examination involves multiple choice questions, so 100 multiple choice questions covering the spectrum of neurosurgery. So there's brain questions, spinal questions, neuroanatomy focused, physiology focused, and various subspecialty focused. And they're really assessing applied medical knowledge of clinical neurosciences. So the format of the question in that exam is often a clinical scenario. So a patient is admitted to your hospital with a severe traumatic brain injury. This is their intracranial pressure monitoring trace. Which of the following is the correct interpretation? So we're asking them often to synthesize some facts and work out the answer of those facts, very much as it would apply to clinical practice. Yeah.
So that's very important to know. So it's not a simple factual recall question. It's presenting a case which is realistic. It's asking a question that involves processing a certain amount of information. So are they hard? Are they difficult? Should they be harder? How do you gauge this?
Yeah, that's a good question. And we're trying very much to make them reflect clinical practice, so we're not just assessing obscure knowledge and facts that you can read or look up on the internet in seconds.
Yeah.
So it's all about applying that information. To set the pass mark, we use a method called the Angoff scoring system. So what that involves is the examiners individually look at each question in the exam, and they assess what percentage of minimally competent candidates would pass that question. So if you've got a really easy question, they're all best choice of 5. So if you've got a really easy question, a scan with an extradural hematoma on, what type of hematoma is this? You'd expect almost 100% of candidates to get that. So your minimally competent candidate, perhaps 95% would get that right. 5% might misread the question, for example.
Yep.
If you've got a really difficult question where it's a guess, 1 in 5 guess, you've got a 20% chance. So the examiners go through each question like that, and then we summate all those scores in a big matrix to give what's called the Angoff score. And then we look at the statistics of that and usually subtract the standard error of measurement to give us the pass score.
So in practice, questions that everyone gets right and everyone gets wrong tend to be...
They're not very discriminatory, those questions.
So they tend to be eliminated.
So we prefer more questions where some will get it right, some will get it wrong. The pass mark in general is around about 58 to 62% in general. Which
is reasonable for clinical practice exams. How about part 2? What does it involve?
Okay, part 2 is an exam for people who really have completed training. Trainees in their final year in the UK are allowed to sit it because their training program is 2 years longer than most European training programs. We asked applicants to submit their logbook summaries before that exam.
Good.
And candidates who've got less than 600 cases in their logbook generally I write to them to explain that they're likely to find the examination very challenging, even if they've completed training. We accept that many trainees are supervised for operations, particularly elective operations, but there needs to be a considerable exposure to surgery to sit the exam.
Okay.
And then the exam itself is 3 oral vivas, each is 30 minutes long. And in the 30 minutes, it's broken down into 5 time slots of 6 minutes. And each 6 minutes, we present a case to them.
Okay.
And we will ask them things about diagnosis, about investigation, about management, about how you operate, how you manage complications, what would you discuss with families. So they're all based around clinical scenarios, real clinical scenarios. We often show candidates scans on an iPad, and that's often the leading question. But it's not an exam in radiology, so we might say to them, this scan showed a posterior fossa tumour, here it is. How would you approach the management of this patient?
Yes.
So that you jump into the higher order questions earlier than you would if you said, what do you think it is?
Great, thank you for that. So if a trainee or a young neurosurgeon, a young specialist wants to sit the exam, often asks the question, is this only available to those who sat and participated in the courses, or is it based on some sort of curriculum?
Okay, well, two answers to that. Anybody who's in neurosurgical training can sit it. They don't have to be on the training course, so they can sit the examination. They do need to be signed off by their training program director or head of department to sit the part 2. In terms of the curriculum, when I took over the exams, I was a bit concerned that we didn't really have a curriculum, but I could see. And we've done a lot of work, and the curriculum should be published in Brain and Spine fairly soon. And the curriculum really describes 3 stages of training: early years, intermediate years, and then the final year or 2 of training. We recognise that across Europe there's quite considerable variation in the length of training, in the amount of operative exposure. So we've tried to incorporate all of that into the curriculum, so there's a degree of flexibility. So the curriculum's really a guide for training programs in different countries in Europe to use, and a guide for the trainees so that they can look at the training program to see what they're trying to achieve. We do give indicative numbers of operations and expectations, but the key thing is really we're focusing on professionalism, on the trainees' ability to communicate with their peers, with families, with patients, on their integrity and on their commitment to further develop their own CPD. So that's a big pillar within the description of the curriculum. And then in the curriculum itself, we've got quite high-end outcomes. So it's not, can you do this, can you do that? It's really that simply, can you manage an emergency take? You don't know what might come in on that emergency take, but
Indeed.
can you manage that? Can you manage to look after inpatients effectively? Can you manage to look after outpatients effectively? Can you undertake an operating list? And that means the planning, the scheduling, making sure all the investigations are available, and then undertaking the surgery safely. And finally, working in a multidisciplinary team is really the 6th pillar within the curriculum, because we recognise it's so important for surgeons to bring in resources from elsewhere so that patients get the best quality and the safest level of care.
That's fantastic, thank you. The curriculum, which is approved by the EANS, is a great job, so congratulations. It's a lot of hard work, which is acknowledged and hopefully be published in Brain and Spine soon. The other thing that I wanted to touch upon is if someone wants to take the exam, sometimes they ask, does this exam allow me to practice anywhere in Europe? Is it a licensing exam?
Okay, it's not a licensing exam, but it's really a currency, so that trainees, when they've got this exam, those who are employing them know where they are in terms of their applied medical knowledge in neurosurgery. So if they've got the part 1, we know they've got a good basis of clinical neuroscience. If they've got part 2, We know that they can talk through complex cases and scenarios. We obviously don't know how safe they are at operating, but the two things come hand in hand. So it's really a currency which hopefully will help the interchange of trainees and young surgeons around Europe.
Indeed, and in fact, from what we know, an increasing number of European countries are using the EANS exam as a standard setting for their trainees, right?
Certainly in part one, it's being used in some countries. Part two, I'm not sure, to be honest.
Okay.
I'll be very happy that it is, because I think it sets a standard. In a way, it avoids duplication of effort across Europe if we've got a centralised exam service.
Yeah.
So I think that's something we'd be very open to. The exam is in English. The examiners are from across Europe. But the exam is not an examination of the trainee's ability to speak English.
Exactly. You mentioned the examiners. It's a lot of work that goes on in the background. Maybe the least recognized amount of work is the examiners. How does someone become an examiner if they're interested? If they're hearing us talk here, how can they volunteer?
I think if they contact the EANS office, we usually increase the examiner pool by about 2 examiners each year to allow for some interchange. And we really want people who've been in substantive posts, specialist posts, for a minimum of 5 years, who are committed to training and committed to further developing our young neurosurgical colleagues. So essentially a CV of their own experience and a covering letter explaining why they should be considered for appointment.
Okay, thank you. Well, I know it's hard work. I've seen it behind the scenes through the EANS board. I can only congratulate you for your hard work and thank you on behalf of everyone for pushing it to the next level. So
thank you.
Thank you very much.
Both a pleasure and a privilege. Thank you.
Thank you, Peter.